why it's amplified. Now, it begins to move down the scale of the stimuli in the perinymph. This whole process, so we have the frequency, as you can see. Down here at the bottom, we have these stiff, short fibers. Okay, this is where we have our highest at 20,000. Remember that those are the numbers I do want you to know, is that we hear 20 to 20,000 hertz. Anybody remember where we have our best acuity? In other words, where we tend to hear the best on an average?
4,000 or 1,500.
Yep. And again, when you look at ranges, a lot of times if you can at least get in the ballpark, it makes it so you don't have to remember the whole entire range. This is one you have to know. That's a big range. You can't just automatically pick an arbitrary number in there. But here, I mean, if you just kind of thought, yeah, we do good at 3,000. Know that there's a little on one side, a little on the other side. You're going to be fine. Okay? Helps to cut down on a lot of unnecessary memorization, which you have to do, unfortunately, with that. Now, this has an area where we have resonance. In other words, it's an area that responds to that frequency. And as it moves down that frequency, or gets to its frequency, it has the potential of making the shortcut. So it's going to come down here, and it's going to begin to vibrate this area. So right here shows an area of resonance. Now, what's going to happen here is that basilar membrane is going to start to shimmy. It's going to start to vibrate at that exact frequency. And we have these hair cells. Remember, we talked about the inner hair cells and outer hair cells. And they exist in this row. Okay? So there's a row of inner hair cells, and there's about 3 to 4 rows of outer hair cells. These have to do with hearing. So what's going to occur here is that as the basilar membrane starts to vibrate, the hair cells, the stereocilia, are implanted in the tectorial membrane. Now again, I think your book, I can't remember if your book says it or not, other anatomists don't necessarily think that they're embedded there, that they make contact there. It's just the shifting of the basilar membrane. But I prefer to think that they are embedded there. It makes the physiology a lot easier to understand. Okay? So as we start to move, these begin to move. Okay? Now there's going to be a couple pictures in here from physiology textbooks, because again, I think it tends to drive the point home a little bit more. So we have kind of an increase in size, and there is one that's the largest. It's called the kinocilium. These are hair cells, by the way. Okay, the stereocilia. These are connected by what's referred to as tiplings, which are specialized proteins. And they look like this. So these are the stereocilia, and these are connected. Now, when we bend the stereocilia towards the taller ones, we have a pulling here. Bless you. And as it pulls, it opens up these potassium channels. Now, this is happening with the endolymph. Remember, the endolymph is the fluid that's on the inside of the membranous labyrinth, which would be the cochlear duct, the scala media. Now, why would it be important that potassium is coming in? What would that do to the membrane potential? Why would it depolarize? More positive. And that's the whole point of depolarization. We're in a resting membrane potential, which is negative, and remember when we talk about this, and this is one of those things that students sometimes continue to forget, and it keeps getting hammered as you move through. This is a membrane potential. Remember, if I was just to freeze a cell, and I added up all the positive negatives on the outside, the positive negatives on the inside, they'd be equal. But the way that things line up in a cell, the negatives are usually right on the inside, and the positives are usually on the outside. So when I open the channel, the positive is going to come in. and that's going to cause the membrane to become somewhat positive. Therefore, we're going to have a depolarization. And then impulses are going to be sent along the cochlear nerve. Okay? Now, when you bend in the opposite direction, those tip links cause the potassium channels to close, which is what's happening here. So here's at rest. Some are open, not very many. This is not a very good representation picture from that standpoint. I like it because it's one that shows the tip links a little bit better. But there is some potassium that will come in on a basal level. But as we start to see here, when they bend in the opposite direction, away from the kinocilium, the tallest of the stereocilia, then we hyperpolarize. And you can see that there are very little action potentials being sent along the nerve. So this is how we hear. Okay? Yes, sir.
At rest, there's still action potential happening. So does that mean the cochlear nerve is still receiving signals?
Not so much. This is kind of the way that we know what our baseline is. So instead of no action potentials at all, there is a basal level of action potentials, but our brain perceives it as absolutely a baseline. Kind of like the arbitrary setting of 0 decibels where we can hear.
Okay.
So it simply is a baseline. There's nothing really being perceived at the auditory cortex that you're hearing anything. It's just the fact that we have an increase in action potentials. And here we have an opposite of a vastly decrease in action potential. So this allows for there to be a resetting back to this.
I remember my last A&P teacher talking about the hairs, how they can be bent in like permanently, like they break.
Mm-hmm.
How does that happen? Like, do they kill the whole hairs, or?
It would potentially, yeah, it would destroy the hair cell. Because if it was bent that way, then you would end up with this massive amount of potassium on the inside, and the cell would eventually just undergo apoptosis, which is cell death. So which is one of the reasons why people shouldn't listen to things really loud, you know, that type of a thing, because that loud noise is really what does a lot of damage over time. We have millions of these. It's not to say that, you know, it's kind of like the whole brain cell things. You should go ahead and use drugs because we really only use 10% of our brain. The problem is when you use drugs, you don't get to pick, you know, which part of the brain is no longer being used, and that's the part that gets destroyed by drugs. So, you know, it's like, oh, I'm not using this part over here. Let's take another hit of acid. It really doesn't work that way, so I wouldn't encourage it. Now, so that, this is the part that I want to make sure everybody's clear, so that we don't have a backward movement. So once it comes through and we're vibrating here, so we don't have a backward movement and a reactivation of these hair cells. It moves through the scala tympani, bulges out the round window, which is a way of kind of absorbing excess energy. So that it doesn't move backwards, and again, you have a secondary reactivation. Now, when we look at, go back to the hair cells here because I want to make sure I talk about them. These, the outer hair cells, basically increase the sensitivity of the inner hair cells. This is a motor component. Okay? Now, for those of you who have had kids, your kid is generally not allowed to be discharged from the hospital until they test their hearing. Okay? So when you're little kids and you participate in school, at least when I was a little kid, you sat in a group of about 4 people and you put on headphones and you were supposed to raise your hand when you heard the noise, and you're supposed to raise it on the side that you heard the noise so that they could evaluate your hearing. It's very difficult to get a newborn to raise their hand. Okay? Yep, I heard the beep. Can I go home now? All right? So what they do, there are a couple different variations of a theme, is they play a noise and it covers the infant's ear. And when the hearing, when an impulse travels along the cochlear nerve and goes back, okay, there is a motor impulse that comes along here to the outer hair cells. And it essentially resets the basilar membrane into a smaller extent, the tectorial membrane. Kind of like, okay, we discharged it, now let's reset. We discharged it, now let's reset. This all happens within milliseconds, okay? When that happens, it makes a noise. It's called an otoacoustic noise. Oto meaning ear, acoustic meaning noise. So, and some people, you can actually, and it's not a common thing, but you can hear their otoacoustic noise. When this occurs, it creates kind of a crackling. So, in other words, how I know that the kid heard the noise was because we played something, the impulse goes up to the auditory cortex, a motor impulse comes back, so that this can change the sensitivity of both the basilar membrane and a smaller extent the tectorial membrane, resetting it, and it makes a noise. And that noise is then recorded. So if the machine does not pick up the otoacoustic noise from the infant, then it means that there could potentially be some hearing deficits while they have to be followed up at a later point. Okay? So that's the primary function of the otoacoustic, or the outer hair cells, I'm sorry.
I feel like that would be really quiet though, so how do you not pick up other sounds that the baby's making? Like if it swallows or if
Because it's all magnified up here.
Oh,
So there's an actual device that fits over the baby's ears and it's fairly tight.
okay.
So it's not something that would be easy to pick up other sounds.
Okay.
Now, we obviously don't want to do it during the middle of a resuscitation, of a delivery, because you've got all sorts of noise. So we do try and have a quiet environment. But it still has that sensitivity to pick up that kind of small amount of noise. Plus, it's going to be happening very quickly. So the noise is played, record, played, record. So, you know, if we play something and the baby Googles or poops its pants or what have you, very rarely is that what we're looking for. Plus, you'll be able to pick up on this stuff. This doesn't make a smell when it makes a noise. Poop makes a smell. Any questions about that component so far? Because all we've done so far is just simply activated the cochlear nerve. Now, here, we're going to go to the spiral ganglion. We're going to go to not just the medulla, but the midbrain specifically. Anybody know why? Our impulses, so again, we're going to be taking multiple buses, kind of like what we did with vision. So why am I stopping at the midbrain?
Reflex.
Inferior colliculi.
My inferior colliculi. So remember our corpora quadrigemina, we had the two top ones, which were the superior colliculi. It regulated sight with our head neck movement. And then this one regulates our head and neck movement to sound. That was that startle reflex I did when I talked about it, in the central nervous system, where if I make a big loud noise, we turn towards the noise. Okay? And then we move on to the auditory cortex from there. So here, we're moving through, we go to our spiral ganglion, we're coming up. Again, we do go to the medulla, but there's a nuclei that's present there that helps to process this, but you don't necessarily need to know that. The bigger part is when we go to the midbrain, where we have our inferior colliculi, and then it's going to go to the thalamus. And we know automatically if we go to the thalamus, we're going to the cortex. Here specifically the auditory cortex. That's sound. Now the nice thing is, as we move into equilibrium, balance, which is our semicircular canals and our utricle and our saccule, the physiology is almost identical. We just have some different names for it. Okay? So here, remember when we talked about moving into the vestibule, the great hall. You don't just walk into someone's living room. Okay? Same with our inner ear. When you walk in, you're in the vestibule. Now, what we do have there are the saccule and the utricle, which contain a receptor called the macula, or the macula for singular. Okay? This has to do with linear movement. Now, if I was to go off to the left, and I don't really mean to use directions because it's also going to depend on what ear we're talking about, but I'm hoping you get an idea. One direction is the cochlea, the other direction is the semicircular canals. So if I go off, I find another receptor that's housed in the semicircular canals called the ambula, or the ambulae for plural. This has to do with angular or rotational movement. So, with the utricle and the saccule, here are the macula, or the maculae for plural. Now, linear motion. Okay, so if we're just standing here and we're not moving, there is, again, just like hearing, there's a basal level of action potentials being set. That just happens to be, we're not doing anything, but it helps to understand changes both increasing and decreasing. Let me go over the anatomy real fast of the macula, and then I'm going to go into how they detect linear motion. So here I have these specialized, epithelial cells, and then I have these specialized hair cells. Again, almost exactly like the hearing. Okay? And if you notice, this one draws a little bit better picture than some of the others. I've got my stereocilia that branch from the hair cells. And if you notice, I've got one that's taller than the rest of them. That's the kinocilium. Now, some anatomists basically, they don't like to call it kinocilium because they feel that kinociliums actually decrease as somebody enters puberty and exits puberty. There will always be the tallest stereocilia. So, kinocilium is perfectly fine to continue to call it that. Okay? Now, sitting on top of that, we have this kind of thick gelatinous material. This is referred to as an otolithic membrane. Again, things should look somewhat similar. We have very similar structure in hearing, except it was called a tectorial membrane. Now, sitting on top of the otolithic membrane, we have otoliths. These are little calcium stones. So when someone says you got rocks in your head, you got rocks in your head. These are little tiny rocks. And then obviously at the bottom of the hair cells, we're innervated by the vestibular nerve. Remember, the cochlear nerve and the vestibular nerve are going to come together to form the vestibulocochlear nerve. Yes, ma'am.
What's the function of the otoliths?
We haven't talked about it yet. Now, the saccule and the utricle, and remember, you have these in both ears. So this is one of the ways that the body is able to tell direction and so forth, because I'm going to show you a picture where it's going to show a head moving, and realize that as I'm moving my head in this direction, I'm depolarizing on this side to indicate that I had movement on the head. On this side, they're going in the opposite direction, which means they would be hyperpolarizing. So my brain is able to interpret, I'm tipping my head this way. Okay? Now, the utricle is for horizontal movement, linear movement. Okay? Now, I can have linear movement in two directions. Forward and backward, that's one. Upward and downward, that's two. Okay? So, these, in the macula and the utricle, are oriented in such a way that, think about being in a car, okay? As you apply the gas, even if you're the most skilled driver, as the car starts moving, you're going to kind of go back in your seat a little bit. Okay? When that happens, this otolithic membrane starts to move. So what's the purpose of the otoliths? They're oriented in such a way that they continue that otolithic membrane moving. It's basically the same thing when we talked about the coup contra coup. They're going to start moving until they get stopped. Now, keep in mind that as you're driving, so let's say that you have a lot of start, stop, you're leaving your house, you're getting on Beltline, you're going to get on I-5 and you're going to drive to Portland, and it's going to be pretty smooth sailing. We're just going to say that you're staying at 75 miles an hour. You no longer have that feeling of linear or horizontal acceleration. Why? Because you're pretty much steady. Everything's caught up in here. Until what happens? You hit hit the brakes, gotta slow down because somebody from Washington's in front of you and they won't get out of the way. Okay? So in that instance, then it moves in the opposite direction. And you have that deceleration that's gonna occur. Okay? Now, the saccule, these are oriented in a different manner. Because saccule is for linear movement in an up and down fashion. Where would you most likely experience that besides jumping?
Elevator.
An elevator. When you get in an elevator, now we don't have a bunch in Eugene because we don't have tall buildings, but if you ever go to a place where there's super tall buildings, you're going to get on and you feel that little bit of a jump. That's that linear acceleration. But if you're going for a fairly good distance, say up to the 81st floor, then you don't really have that acceleration anymore because everything's caught up. There's plenty of time for the hair cells to reset themselves because you're no longer really accelerating. You've now achieved kind of a steady state. And you're just riding in your elevator until what happened?
You stop.
Or right before you stop, you're getting close to your floor and the elevator will begin to decelerate, slow down. And then you have that feeling of, okay, slowing down. So you have the initial part where you have a change in your acceleration, and as long as that acceleration then reaches a steady state, stays the same, everything's done. So when we look at this, here I've got my otolithic membranes, here's my otoliths, here are my hair cells, my stereocilia, my kinocilium, the tallest of the stereocilia, again innervated by branches of the vestibular. So here, we're in this position, and remember I told you there were basal levels of action potentials. Even though nothing's moving, the basal component is sending some action potentials. Now, when you tip your head, the otoliths are going to start moving and kind of help the otolithic membrane move in that direction. When that occurs, we're bending towards, and this might be hard to see from where you're at, but here's my stereocilia, or my kinocilium, and the rest of them are bending. The physiology is exactly the same as this. The tip links are causing an opening of the channels, and we have depolarization. Now, when we look at this picture, when I come back up to a perpendicular, or when I'm no longer really bending per se, then I return back to the action potentials at rest. If I move to the other side, I'm hyperpolarizing, and look how slow or few action potentials are there. It's one of the reasons why it's important to kind of have that basal level. Because when I hyperpolarize, it slows it down even more. Now, I just want to drive the point home. This, again, it's a great picture from the standpoint that it shows all the parts and what they're doing, but it makes it look like this is dead center in the middle of their head. Okay, this would be on one side. So when this is happening, let's just say on the right side, this is happening on the left side. Therefore, my brain is able to interpret, I'm bending my head this way. Okay?
Is that the basis for proprioception?
Part of it, because we'll talk about it at the end, because there's proprioception is going to take in multiple inputs. It's going to take in the proprioception from our muscles, but we also have our ocular inputs. So I'll show you a diagram that's going to kind of drive the whole point home. So this is our static or our linear acceleration. Okay? Now we do have these semicircular canals. Again, bony labyrinth. In the middle of the bony labyrinth is the membranous labyrinth. The membranous labyrinth is filled with our endolymph. Surrounding the membranous labyrinth is our perilymph. And so when we have that process, these are, and this comes again, comes from a different textbook. Okay? It shows you how the semicircular canals are oriented to be able to tell you different movements. And so they use a corner of a room so that you kind of get an idea. So you have the superior, you have the posterior, and you have a horizontal canal. Okay? The horizontal canal would be used if I was doing this. That's an angular motion. Okay? Here, it's kind of like what we saw on the previous picture, kind of a tilting from a right to a left. And then superior is oriented in such a way when you do this. Okay? And I'm not going to ask that specific on an exam. What you should know is the fact that you have 3 semicircular canals, and they facilitate you detecting motion in different angles. So I am not going to ask you which one tells you which that you're nodding your head, which is the head shaking, and which is the one for the head tilting. It's not going to come up on an exam. But again, the fact that there are 3 of them, and that they detect rotational or angular movement is the important part. Now, again, the structure, this is the ampulla. That is the receptor for angular movement. Where is it located? Semicircular canals. The macula is the receptor for linear movement. Where is it located? The saccule and the utricle. So here, very similar shape. I've got specialized cells. These are the hair cells here. They have these innervation from branches of the vestibular nerve. And then we move up and we have our stereocilia with our kinocilium with tall one. Now, it also has this mass, okay, that kind of sits on top of it. And it's referred to as the cupola. And that works very, very similar to the otolithic membrane, the tectorial membrane, because as we start to have movement, we have the endolymph, which pushes against it. When it pushes against it towards the tallest one, the kinocilium, we have depolarization. Now, as this process, this is one of the things that's a little bit harder to grasp. So, when you get dressed up and you go ice skating, you're going to start spinning. Now, as you start to spin, the fluid is actually going to be moving in the opposite direction of what you're spinning, pushing the hair cells that way. And it's going to do that until you basically catch up. And when you catch up, you don't really have that sense of twirling, depending again on how fast you go, because we can certainly override this. If you've ever had a friend who's kind of a turd and you were on the little merry-go-round and they just spun you and you can't get off and you can't stop it and you feel like you're going to vomit, then you really never get to play catch-up. Okay? But if you have the ability, as you spin, to constantly be looking at sights, which is the vestibular, which is the ocular inputs, the visual inputs that kind of help the balance system, then that helps you to kind of figure out where you are in space. Okay? Now, this will eventually come to a nice, even pathway. In other words, the endolymph catches up and it just kind of turns and nothing is happening here until what? You stop. And as you stop, it's still spinning in that direction. Then continuing to activate until you've got a little bit of time and it stops. That's the reason why when you get off of the merry-go-round, you still are somewhat dizzy, because the endolymph hasn't caught up with the fact that you have stopped moving. It's a fluid. The fluid is going to continue to move in one particular angle. And I don't need you to spend a lot of time trying to figure out, well, spinning it, the take-home message is the endolymph is going to start as you start, and it's going to go in an opposite direction. It will eventually come to a stop as you continue to move in that direction. Like the linear acceleration. We don't feel it anymore. So you don't sit in your car at 65, 70 miles an hour on I-5 and feel like you're accelerating. You can see the fact that you're going somewhere because you have these visual inputs going by and you can see the cows and what have you. Same thing is true here. It will eventually, the endolymph will eventually come to a halt until you stop. And then it will move in the opposite direction. The opposite direction that you're spinning. Okay? So some people use a paintbrush, and it's, I'll see if I can find a picture and put it on Moodle, because it sometimes paints a different picture. But as you start to paint, you know, the bristles go this way even though you're moving that way. It's the same kind of a thing with the hairs up here. Okay? Now, with this process, so again, towards the high part, depolarization, when it goes in the other direction, or hyperpolarization. So this is what I was referring to with how your body essentially handles this. So we have the vestibular receptors. So that's the stuff that's coming from the semicircular canals. We have visual receptors, and then we have our proprioceptors. This is what is going to basically say, okay, how are we going to handle this? I've got all these three inputs, and I got to figure out, why am I spinning in ice skates in a short dress? And then we start to have our movement get coordinated. We have our eye movements. This is one of the things, by the way, that's checked if you have a field sobriety test. It's called an astigmas. So if I was to put you on a merry-go-round and spun you and spun you and spun you, your brain is trying to, again, pick a spot so that you don't feel like you're going to throw up. So when you get off, your eyes will be moving back and forth. It's called an astigmas. Okay, and I think I have a video that I'll have to double check. A girl kind of spins and you'll see the eyes moving in a particular direction. So that's one of the things that the officer's looking for when they pull you over, is do you have an astigmas? It's not just the simple, toot your head back, and because that in and of itself, I mean, if we're all, hopefully at 8:30 in the morning, sober, as you tilt your head back, I mean, you really have to concentrate. It's hard to do. So there are multiple things that go into, are you under the influence or not? That's one of the reasons why, I'll get your question in just a second, that's one of the reasons why, if you're somebody who is prone to motion sickness, where do you normally sit in a car? Where's the best place to sit in a car? Why?
Because you can see everything.
Yeah, because I have a longer opportunity of looking this way as opposed to looking at the side where things are just going by, like no one's business. Here I can see the cow, up there, and I can pay attention to the cow, and then my visual input can basically override some of these impulses. Now we can dampen the response down. You can use acupressure. You can use ginger is another thing that has a tendency from a non-pharmacological component. We have boning, so anti-nausea medication. Dramamine fits in the boning category. They're things that people take for motion sickness.
Do one of those three have priority over the other? So like for nystagmus, if the vestibular receptors were, like the otoliths were moving, or they broke off or they were moving and it made the sensation that you were still dizzy, would it cause your eyes to go into like a nystagmus?
Yeah. So there are the people that have motion sickness, basically these three things aren't playing well together. One of them overrides it. Okay. We had when I was the coordinator of the neonatal transfer team, we had people that would do ride-alongs if they kind of thought this might be something I would like to try. And we had a nurse, we were picking a kid up in Florence, and we usually obviously go 126 over. We had to leave her because she had vertigo. And vertigo there's a lot of things that go into vertigo. It's not just simply a fear of, this height where you look down. It's this whole perception component. Meniere's disease kind of fits into that whole thing. Tinnitus, where you have a constant activation of either the ocular, or not the ocular, the cochlear nerve, or because it travels along the same process with the vestibular nerve, and then hitting the vestibular cochlear nerve. And she basically was there for 3 days. She got such bad motion sickness on the way over that we couldn't even bring her back. So needless to say, she didn't get on the transport team because we go all over this area and it's windy and doesn't really do any good. I've got a critically ill infant, a newborn, and I've got a nurse that, basically is incapacitated. So yeah, there are components where these three things don't play together, where one trumps the other. The two biggest ones are these two, obviously. This plays a much smaller role in general. And don't worry about these unless we have time, and I'll talk about them. I want to make sure we get everything else covered. So that's special senses. So again, it might seem like a lot of information, but when you're looking at hearing and you're looking at balance, the only thing that's really changing is the structures. The physiology is the same. I've got these hair cells, and the hair cells has fingers on them. The stereocilia, there's one that's bigger than the other. When they tend to bend towards that one, you have depolarization, and it travels along the nerve to either the vestibular cortex or to the auditory cortex, whether we're talking about hearing or whether we're talking about balance. If I bend away from them, we hyperpolarize. So you should know, how hearing works and the structures of hearing. You should have an idea about linear acceleration, the saccula and the utricle, and the receptor is the macula. For rotational movement, angular movement, the receptor is the ampulla. Ampullae for plural. And you should know where they're located. And then you should know the structures. So I have my otolithic membrane, I have my otoliths, and the other one, I've got my cupola, still have the hair cells. Okay, so you don't have to get too much into the weeds on how, again, the whole spinning aspect. The take-home message really has to do with the direction of the hair cells and what leads to depolarization, what leads to repolarization or hyperpolarization. Any questions? All right, why don't we take a short break? When you come